Okay. Welcome everyone to the National Centre for Immunisation Research and Surveillance's December seminar webinar on working together to improve Aboriginal and Torres Strait Islander immunisation. So I'd like to start first by acknowledging that we're meeting on Darug land here in Westmead, and pay my respects to elders past and present, and to all Aboriginal and Torres Strait Islander people here today, and anyone present online as well. So we've got two great speakers today. Note for the online audience that you can submit questions through the Q&A button at the bottom of your screen, and we'll save those up and ask them at the end of the seminar. So our first speaker today is Katrina Clark, who's the National Indigenous Immunisation Coordinator here at NCIRS, has been here for 3 years now. And Katrina's a proud Barkindji woman from far western New South Wales who's worked in immunisation for many years, from the coalface up to national level.
Well, thank you, Frank, for that lovely introduction. So prior to starting any presentations, I just also like to acknowledge our country. So Australia, this beautiful country that we call home, always was and always will be Aboriginal land. I acknowledge and pay respects to our ancestors, to our elders today, and the generations to come, for they hold the memories, the traditions, and the future of First Nations peoples. I would also like to extend that acknowledgement to our non-Indigenous colleagues who walk with us and continue to support the best possible outcomes that will not only affect today, but in ways that future health services are provided to all Aboriginal and Torres Strait Islander people. So just a bit of a background about me for those that don't know me. As Frank said, I'm a proud Barkindji woman, and the photos on screen are from the country that I belong to. So it's Ivanhoe, far western New South Wales, and that is the main street of my little home community. So currently, I think the population is just under 80 people. Yes, and then the two photos just down on the bottom as well as the country now that I live on, the beautiful country in Newcastle, so the country of the Awabakal people. So today I will be providing an overview on existing opportunities for improvement, highlighting inequalities in disease burden and vaccination coverage for Aboriginal and Torres Strait Islander communities, as well as discussing the rationale behind the current immunisation schedule for risk groups. And a lot of what I'm going to be showing you today that comes from both these reports that were recently published, and if anyone would like to take a hard copy of the vaccination for our mob, they're just over on the table as you walk out. Historically, immunisation has been and remains a simple, timely, effective and affordable way to improve Aboriginal and Torres Strait Islander health, delivering positive outcomes for Aboriginal people, for all people of all ages. However, Aboriginal and Torres Strait Islander children still experience higher rates of vaccine preventable diseases compared to non-Aboriginal children. So during this presentation, I hope to answer a few questions to why the NIP schedule is different for my mob by giving examples of VPD burden disparities as well as highlighting the NIP gap, so the National Immunisation Program. This graph shows the rate of acute hepatitis B notifications in all ages by Indigenous status in Australia in 2006 to 2015. In the time period, we can see a decline in notifications in Hep B for both Aboriginal and non-Aboriginal people. Low rates of acute hepatitis B notification and hospitalisation in both Aboriginal, Torres Strait Islander people and other Australians aged less than 15 years of age reflects the success of the universal infant the Universal Infant Hepatitis B immunisation program. However, acute hepatitis B notifications are still 3 times higher overall. 8 times higher in 15 to 25-year-olds, which may be due to the low uptake in the school's immunisation program. You know, and while the current Australian guidelines recommend hepatitis B vaccination be offered to all Aboriginal and Torres Strait Islander people, vaccination for Aboriginal and Torres Strait Islander adults is not currently funded under the NIP. It's also it's funded by some states and territory, but the uptake is not good. This graph shows the rates of Hib disease notifications in persons under 15 years of age by Indigenous status. Hib disease is 10 times higher in children less than 15 years of age. So the rates jump around a little bit. So that's the blue line we're looking at for Aboriginal and Torres Strait Islander people. You know, the rates jump around due to the small numbers of notifications. Since the introduction of Hib vaccine in 1993, invasive Hib disease notification rates have decreased by more than 95% in Aboriginal and Torres Strait Islander children less than 5 years of age. But overall, the rate is still 10 times higher. Vaccination coverage is good. However, timeliness is an issue. You know, improving timeliness will help. However, to close the gap, we also need to address the social determinants of health, so such as house crowding. This graph shows the rates of invasive pneumococcal disease notifications by age and Indigenous status in Australia between 2006 to 2015. Environmental and social determinants of disadvantage factors include household crowding, high smoking rates, are most likely causes for the continuing disparity in both Hib and meningococcal disease. You know, the burden of IPD disease remains high in Aboriginal people despite long-standing vaccination programs. So as you can see by the blue line, it's 3 times higher in our, you know, under 5 years of age and 10 times higher, which in our 5 to 49-year-olds, so that's the solid red line. And then also 10 times higher in our over 50 years of age. So that's the green line. Extra pneumococcal vaccine on the NIP for Aboriginal and Torres Strait Islander people. So I've just shown you the notification. So let's look at the NIP schedule. All children receive 3 doses of Prevnar 13 at 2, 4 and 12 months of age. Aboriginal children living in WA, Northern Territory, South Australia and Queensland, so they receive an extra dose at 6 months of age due to the increased risk of IPD in these communities. It's similar as well to other Australian children who are medical at risk. And we also have our adults. Its pneumococcal vaccine is given under the NIP to Aboriginal and Torres Strait Islander people aged 15 to 49-year-olds who have underlying medical conditions or who are smokers. All Aboriginal and Torres Strait Islander adults over 50 years of age receive the pneumococcal vaccine on the NIP schedule, as well as non-Aboriginal people aged 65 years and over. This graph shows the rates of meningococcal notifications by type in Indigenous status in Australia between 2006 to 2015. As you can see by the red line, which is right down the bottom here, the solid red line, meninge C notifications have almost disappeared since the commencement of the meningococcal program in 2003. However, meningococcal B rates are still several times higher amongst Aboriginal and Torres Strait Islander peoples than our non-Indigenous counterparts. As you can see with the blue line, it's meningococcal B, meninge B is still 4 times higher in our less than 5 years of age and 6 times higher in our 5 to 14-year-olds. So that's the blue line. Now, despite this, meningococcal B is still currently not funded on the NIP. Factors such as household crowding, cigarette smoking, exposure is likely to contribute to these highlighting these rates. The period covered in this graph, meningococcal W and Y have also emerged as causes of diseases with much higher rates in Aboriginal and Torres Strait Islander people. Meningococcal ACWY was added to the National Immunisation Program in 2008 for all children at 12 months of age and also for adolescents over 15 years of age. However, should we be giving it to all Aboriginal and Torres Strait Islander children aged 5 to 14 years of age as well? She's not looking at me. Just looking at Christine. And then we've got nerve rotavirus hospitalisation rates age less than 5 years of age. So looking at the solid blue line, we can see that with the commencement of the rotavirus vaccine program on the NIP in 2007, there was a sharp decline in hospitalisation rates in Aboriginal children under 1 year of age. Looking at the solid red line, we can see similar decrease in children aged 1 to 4 years of age. So that's the solid red line. However, these are still higher than the rates in non-Indigenous children. So these are represented by the broken and the dashed line. So they're the non-Indigenous children, where the solid lines are Aboriginal and Torres Strait Islander children. If you compare these rates before the vaccine came in 2006, the rates in 2015 has been a 60% decrease in Aboriginal children, but in non-Aboriginal children, the decrease was 80%. That's overall, the rate is still 5 times higher in Aboriginal children. The same vaccination schedule for Aboriginal and Torres Strait Islander children, however, reported coverage is still very low. This could be due to the timeliness issue, as there is an upper age limit to able to receive this vaccine. This is why it's important that we all promote on-time vaccination for our most vulnerable. This graph shows the hospitalisation rates due to pertussis for all ages by Indigenous status in Australia between 2006 to 2015. As we can see, that this is higher for Aboriginal people of all ages. Overall, the 2011 to 2015 period, hospitalisation rates for infants was twice as high in Aboriginal children. To reduce the burden of pertussis in our vulnerable infants, it's important that we promote to improve timeliness in infants' vaccine doses, particularly in the first 2 doses, which is which offers significant protection. Oops, sorry. We also need to promote maternal pertussis during pregnancy. In 2006, the DTPA was funded under the NIP for all women during their third trimester of pregnancy, including all pregnancy that are closely spaced, to provide maximum protection for all infants. This graph shows the hospitalisation rates due to influenza for all ages by Indigenous status in Australia between 2010 to 2013. We Aboriginal and Torres Strait Islander people are more likely to get severe flu or influenza and need treatment in hospital, with young children more at risk and likely to get very sick with serious chest infections ending up in intensive care. It's the most common VPD that sends children to hospital with disease burdens highest in the under 2 years of age, with the hospitalisation burden highest in those aged under 6 months. Rates are higher for all Indigenous people compared to non-Indigenous people across all age groups, but particularly for our most vulnerable. So Indigenous children under 2 years of age are hospitalised at more than the rate of non-Indigenous counterparts, and our Indigenous elders over the age of 50 years of age are hospitalised at approximately 3, so you can see here, 3 to 4 times the rate of non-Indigenous counterparts. Now, the vaccine is now funded on the NIP for all Aboriginal people aged 6 months and over. The vaccine is not licensed for under 6 months of age, so it's really important that we ensure all of our pregnant women receive the routine influenza vaccine to protect not only mum, but the unborn bub as well during the flu season. Now, here's a real success story. Following the introduction of hepatitis A immunisation program in 2005, targeted at Aboriginal and Torres Strait Islander children aged 4 to 12 months in Western Australia, South Australia and Northern Territory, we have seen that hepatitis A notification rates in Aboriginal and Torres Strait Islander people have declined sharply and have remained lower than those in non-Indigenous Australians. So you can see the blue line, which is the sharp decline in 2007, and currently we're still doing pretty good compared to our non-Indigenous counterparts. We can see a similar success with the measles notifications as well. So Aboriginal and Torres Strait Islander people now experience relatively similar rates of measles than other Australians. Most measles outbreaks in Australia are linked to people who have been infected overseas. In 2014, local measles transmission in Australia was verified as being eliminated. And to keep measles under control, it's important to continue and maintain high vaccination coverage. So in summary, today I've shown you that despite successes, there is still disparity in a number of VPDs. Vaccine coverage is pretty good, and in fact, the latest coverage data shows immunisation coverage for Aboriginal and Torres Strait Islander children to be at a record level across all ages. However, delayed immunisation and vaccine-preventable diseases remained a significant health issue in Aboriginal children, Aboriginal and Torres Strait Islander children. And this is why we need to focus on making sure that all Aboriginal and Torres Strait Islander children receive their scheduled vaccines in a timely manner. And finally, in relation to the vaccination schedule gap, we have closed the 5 to 14-year-old age gap for influenza, with the age group now eligible to receive an annual influenza vaccine. However, there is still an obviously gap in the meningococcal vaccination program. especially given the high rates of meninge B. The question is why? The question is why this life-saving vaccine is not funded under the NIP. So what can you do as a service provider? It's important to know whether a patient, a client or a consumer identifies as Aboriginal or Torres Strait Islander, as this ensures the care and services provided are both clinical and culturally appropriate and responsive. Correct identification also helps you to provide referrals to other services, such as recommending screening and health checks at the appropriate ages. Referrals and links to external services that are designed for Aboriginal and Torres Strait Islander peoples, including community support organisation and medical services located in your local community. Community-driven program design is fundamental. This requires building long-term relationship and engaging with communities that go well beyond the superficial consultation. That's critical to this process is having staff who are part of the community and draw on the expertise and support from staff with a diversity of background. Much of the health service sector treats the illness in Aboriginal people rather than promoting good health. Delivering a person-centred healthcare that is critical, or that is culturally capable, safe and responsive. This shift in power and places clients' needs, desires, goals and values and circumstances at the centre of care. And be aware of the National Immunisation Schedule, as some vaccines have different recommendations for Aboriginal and Torres Strait Islander people. As seen, the burden of disease is much higher in Aboriginal and Torres Strait Islander people. And continue to offer immunisation opportunities at all visits. And finally, I can't go by without showing the success of this great success that began in Hunter, New England, and now is a statewide program. You know, the program employs Aboriginal immunisation healthcare workers working with community and successfully lifted the rates of Aboriginal and Torres Strait Islander children being immunised. All 13 are doing a fantastic job in engaging Aboriginal and Torres Strait Islander families. You know, this is just one of many examples of when First Nation peoples lead the way, we can close the health inequalities of the world's oldest living surviving culture. Our health, our culture, our health, our voices are strong. Or as we blackfellas say, it's deadly. We are not the problem. Our culture, our voices, we are the solution. And that is what all Australians should be proud of and embrace. Not only we live in the best country in the world, but you'll also live alongside the world's oldest living surviving culture. With 60,000 years of genius and imagination in our hearts and minds, now is the time for services to allow Aboriginal staff to lead, to be part of the solution that transforms the future of health services, as well as delivering health services. It's time to think differently. And with that, now I'm going to hand over to the wonderful Patrick Cashman to share his experience of working and designing, not a top-down approach, but more importantly, from a ground-up approach. Some may look at this as taking risk, but Patty knew we had to try something new, as what the local health service was doing at the time was not working. Thank you.
Okay, great, thanks Katrina. So we'll hold the questions till the end of the session. So our second speaker, as Katrina said, is Cashman, who's the immunisation coordinator for the Hunter New England Local Health District. And people online who can't see the presenters. Katrina's last slide actually had a picture of both presenters, Katrina and Patrick, in the very colourful Aboriginal shirts.
Oh, sorry.
Thanks, Frank.
Patrick looks older now.
It's true. A big thanks to Katrina. That was a fantastic presentation. That was wonderful data, and you put that together really well. Well done. Nanana Nyangu Bana Ananonka. Nai Nananko Yupakunka Watinganko Nananka. Waro Nyalanko Yila. Kwari Nura Wari Waro Chukaka Nanano Waro Watia Ananonko Jakut Janganko Workaringa Jabi Kutaki Wia Yanapa Nurinini Wakano Pipa Chukaka Yanano Chunanani Kulani Palaru Yukarinka Wia Kuchu Katu Anano Kuli Wia. Wakanani Lirianu Liri Wanka Kanmapa Chuta Nanana Nulimpe Kuliko Wakari Yanano Chuluwana Liri Yua Yanano Chukaku Kulia. My apologies to literature people west of Alice Springs who speak that as their first language. That's literature. So I've tried to use language here as an illustration of Aboriginal ways of understanding. There's probably an expectation in the room and around the country that I would speak in English, and I'm going to from now on. That's my literature, full extent of what I know in literature. But I just wanted to illustrate the point that usually it's Aboriginal people that have to do things our way, and we need to think about doing things an Aboriginal way, even though sometimes it's not easy. So Aboriginal and Torres Strait Islander people are often excluded, and their expectations, hopeful expectations, are often dashed. Like you had expectations I was going to speak English today, and your expectations were dashed, and you thought, what was going on? But that is an illustration of what Aboriginal people experience all the time. For some, it's language, but most Aboriginal people don't speak their own language. So was about 300 to 400 languages with another 300 dialects, so like 700 different languages in Australia in 1788. And only about 60 are in regular use at the moment. So that's a huge loss of culture, a huge loss of wisdom, a huge loss of understanding. So we look at this map there, there's like 700 languages and dialects represented, but only 60 spoken regularly. So it gives you like a visual illustration of the decimation of Aboriginal culture over the last 250 years. And each Aboriginal person's experience is different. So some people will speak English as their third or fourth language. They'll speak 3 or 4 Aboriginal languages first. Some people don't have any words of their own language because, especially here on the East Coast where colonisation started, because that's been lost. There's been stolen generations, and that wisdom, that culture has been separate and it's lost. So some people are starting to reclaim that. And there's a great movement of Aboriginal people reclaiming their culture and reclaiming that wisdom. But each Aboriginal person's experience is different. And when you're working with Aboriginal people, you really have to acknowledge that. And just because you've worked with one Aboriginal person and it's worked well, start again with the next Aboriginal person, because their experience will be completely different. And although I've used language, the migrant experience in Australia is a unique experience to the Aboriginal experience who were here first. So I'm using language to illustrate, but I don't want to get mixed up with migrant experiences. It's a different experience. So I've just tried to use language as that demonstration. And we have to remember there's a lot of institutional separation of people, institutional racism, and we have to make sure that we're working against that. So 30 years ago, there was a Royal Commission in Australia looking at Aboriginal people being overrepresented in prisons. And today, 30 years later, we've still got 28% of the Aboriginal of the prison population being Aboriginal when they only represent about 3% of the population. Earlier this year, we had a banking Royal Commission, and people have been shown to be crooks, but they're not in jail. So if you've got unpaid fines, you go to jail. If you rip people off, if you're a banker, maybe not. So we've got to look for system problems in our own work. So Katrina's pointed out the fact that influenza vaccines not funded for 5 to 15-year-olds. And Aboriginal people come to the doctor in family groups. So they might not be high risk, so it doesn't look like they need it on the graph. But when they present in family groups, that's the way we need to be looking after people. Another obvious one is the average age of male Aboriginal people in Australia, the average age of death is 70. And Zostavax only gets funded at 70. My statistics aren't too good, but I think half the blokes are missing out on that. So how do you work with Aboriginal people? There's some great information. And we traditionally have started with a deficit, that Aboriginal people are missing all these things, and we've got to start with what's missing. But we need to turn it on its head. And there's great work now looking at a strengths-based approach. And there's documents like this that you can find. And every state and territory has wonderful cultural guides that will guide you in how to work with Aboriginal people, local, a lot of cultural information. It's absolutely fantastic stuff. And I implore you to seek those out. But when working with Aboriginal people, start with the strengths. We've still got 60 languages. We've still got people claiming words and things. So that's fantastic. And you'll find a wonderful generosity when you're working with Aboriginal people. Archie Roach is a wonderful Aboriginal singer from Victoria. Sing out to all you Victorians online there. And this is a cover from his album, Into the Bloodstream. And he did this album not long after he was sick. He had a stroke and then he had lung cancer in about 2011. And it's that's the cover of the album, and you can see it's a beautiful picture. But it's a lovely amalgamation of two things there. So on the left-hand side of the screen, in yellow, is a picture down a microscope of a white blood cell, and it represents the white way of looking at his illness and who he is. And on the right-hand side, in the reddish colours, that's like a Aboriginal painting of Framlingham Mission where he grew up in Victoria, and that's like an aerial view if you want. And the little white dots are the huts, and he can point to the hut that he grew up in. So that's put together, they make a lovely aesthetic, pleasing picture together. And that's the way we need to be working with Aboriginal people, is putting it all together, because Aboriginal people bring a history, bring a personality, bring who they are to the hospital, to the clinic, to where we are working as health workers. So Archie Roach has really symbolised that nicely. And if country and western's not your thing, he's just done a great album with Paul Grabowski with a jazz background. So I thoroughly recommend that to you, released about 2 weeks ago, if you're a bit more highbrow. And there's different ways of looking at things. So there's one, we all know that Uluru, the climb, got closed recently. And this is Don Fraser, who was on the park board there. And this is his way of looking at it. It's about time the rock had a rest. rather than the tapping of shoes all the time. And I think that's just a lovely illustration. So me as a Westerner, I don't look at a rock and I don't think of the rock needing a rest. But there's different ways of looking at things. And if you're coming in with your own worldview and you're pushing your own worldview on other people and you're not listening, you're going to miss these insights. And if you miss the insights, your health programs are not going to work. So that's just a lovely way of looking at it. A lot of Aboriginal languages generally don't have a word for thank you, because the whole culture is based on reciprocity, it's harder to say than some of the literature words, and obligation. So there's no need for a thank you because you're always doing things for other people. It's what's expected. It's just what happens. You don't, if someone does something nice, it's not a surprise because it's just what happens all the time. Yeah. See, some people, I've heard people tell me, oh, there's no word for thank you. Well, you know, what are they doing? It's actually an asset, not something that's missing. And if you're working with Aboriginal people, you've got to respect Aboriginal ways of working. Yeah. You employ Aboriginal people to be Aboriginal people. So when they are Aboriginal people, you don't get upset that they're not working in a white Western way. So family is very important for Aboriginal people. So they might take phone calls from family during work, but that's what you'd expect because that's the value Aboriginal people have. Indigenous ways of knowing, you have to be looking at research, and a lot of people online here and in the room are researchers. So there's an Indigenous research to highlight Indigenous ways of knowing, and we need to be looking for that and making space for Aboriginal ways. And a sing out to Dee in Camperdown who put this lovely picture together. There's a young Aboriginal researcher I know, Christy Crooks, who's doing some great work, and she's done this great project on healthy skins. It's 3 communities coming together. She did that artwork. And in health, we're always trying to save lives, and we start at the end where people are dying the most. But when Christy and the researchers with her went to the communities, they said, oh, we're really worried about skin sores. And there's lots of work in Central Australia and top end in the Territory, remote, on skin because of post-glomerular nephritis, post-strep glomerulonephritis. But in rural and urban areas, not so much. So she did this wonderful project, and now they're selling soap, and they've reclaimed a lot of the wisdom that was missing before. So that's a wonderful illustration of how to do really good research. And this is the health assessment that goes with that project. And they've got all the normal stuff you'd expect on a health assessment for skin, but they've also got the social determinants of health. So housing and things like that are on the health assessment because you need to be thinking more broadly. I love this picture. This is fantastic. So this is some great work by Lucy Dang and others put in the MJA in 2017. And this is on the x-axis. There's the birth year of Aboriginal women when they're having their blood taken, when they're having babies. And you can see there the green line along that sort of parallel to the x-axis is Australian-born non-Indigenous women, always quite low rates of hepatitis B. The blue line in the middle there is Australian-born Indigenous people. And you can see there the rates were very, very high. Now, back in the day, the hepatitis B antigen was actually called the Aboriginal antigen, because if researchers needed to work with hepatitis B, they were guaranteed to find it if you were bleeding Aboriginal people. So the really, really high rates. And you can see that rates come really right down and nearly joins the green line. And this is amazing because this is not the work of one person. This is doctors and nurses and healthcare workers and communities and Aboriginal medical services and GPs and hospitals and maternity services all around the country, sometimes in tin sheds, sometimes in big hospitals, all working together to get this down. So this is a wonderful illustration. And also hepatitis B vaccine was free, funded and provided for Aboriginal people way back in the 90s. And that's where it had a huge effect. So this is a wonderful story on the back of a lot of hard work by a lot of people. And this is fantastic. So that's sort of what we want to emulate in lots of different things. So when I came from the Territory to New South Wales, I was amazed that there were no Aboriginal health workers in public health units in New South Wales. And there was a gap we had an 8% gap in the outcomes for mainstream kids and Aboriginal kids getting immunised on time. So I thought, I can't do anything about it. I need to employ Aboriginal health workers. I employed Natalie Allen and Katrina Clark, and together they were contacting young mums, and it's just a fantastic program. And if you're going to start working with Aboriginal people, then employing Aboriginal people is a really important place to start. Now, this has become a New South Wales-wide program. I had nothing to do with that. The Sue Campbell-Lloyd found some funding for that, and big thanks to the Immunisation, New South Wales Immunisation Unit. And now this has got ongoing funding, and it's an integral part. And what's nice about this is sometimes we employ Aboriginal people, so someone leaves a job, and we say, oh, let's make that an identified position. But this was new work. This is new money coming in. So that's absolutely fantastic. And they, New South Wales Immunisation Unit do a great job because it's not prescriptive. They don't tell the 15 Aboriginal health workers around New South Wales how to do their job. They know their communities, they do their job, and they've closed the gap. So it's not telling people what to do. But what they have done is give people the resources. What's not uncommon is you employ an Aboriginal person, you give them a workstation and a computer, and then you come back in 12 months' time and you see if they've met their KPIs. Giving them no support, no tools, that's not going to close any gap. That's not going to do any good. So how did we do that? Governance was really important. The local Aboriginal people asked us to do something about it. They could see that the immunisation rates, when we showed them the data, the immunisation rates for 12-month-old Aboriginal kids were not as good as the rest of the mainstream kids. You can't do anything without good data. So you've got to present the data. And if you work in data, you've got to be good at your job. Aboriginal people don't want second-rate help. They want people who are really good at their job. So if you're a statistician and epidemiologist, there's lots and lots of scope to be really good at your job, present the data, and if you know the problem, then you can find the right solution. If you don't know the problem, you're just making stuff up. And we took advice. Now, when we started working with Aboriginal mums, Natalie Allen was the Aboriginal health worker who just had one person employed at that time. And she said to me, gee, we're getting all this hospital data, but we're missing all these Aboriginal kids. They're not being identified. And because she knew her community so well. So you get all this intelligence, you get all this wonderful insight when you work with Aboriginal people who know their community really well. And she wrote this up beautifully in the New South Wales Public Health Bulletin a while ago. Oh, okay. I don't always get things right. And if Natalie's in Tamworth listening to this, she'll be saying, oh, yeah. Big talking yourself. But I do lots of things wrong. And Aboriginal people are being mucked around a lot. They need you to be reliable. If you say you're going to do something, then follow through with it and do it. Yeah, don't talk it up if you're not going to do it. And I don't do this very well, so it is a note to myself, but it's also oversharing with the audience. So this is what we have from 2010 when Natalie started, and then Katrina shortly afterwards. You can see the gap there closed, and now it's less than 1%. And the most recent average 4-quarter gap is just 1%. So that's absolutely fantastic. So we're very proud of this, and that's why I've got it up on the screen for everyone to see. But it takes a lot of work because obviously the kids born now, the fact that someone was immunised 12 months ago doesn't make any difference to the kid born today. So it's an ongoing project, an ongoing work. People move around, AMSs change. So it's ongoing working with organisations, individuals and families. So this is the 3 age groups that we look at from the AIR data, the 12 months, 2 years and 5 years. And you can see there that the purple line there is the data we just had a look at. It's the 12 months old. And you can see there's a gap between mainstream, which is 0, and the purple there, which is the Aboriginal kids at 12 months. You can see that the blue line has moved around. They're the kids at 2 years. But most impressively, the red line there, the kids 5 years before they start school, are actually better immunised. There's a negative gap, which is what we need to be aiming for in all our programs. So this is a timeliness story as well, so that the Aboriginal kids eventually end up better immunised than the mainstream kids when they're off to school, but it takes a lot longer. And as you know, if you're leaving young children unimmunised, they're vulnerable to infectious diseases, vaccine-preventable diseases. So that's not what we want. So again, even though we've done really well, there's still lots of work to do on timeliness. And sometimes this is what Aboriginal immunisation looks like. So this is a story from the Moree Champion, which is it's not an athlete, it's the local newspaper. And this is Charlene on the right, and Alina, the nurse, who's vaccinating the kid. And they did a really good job in Moree of finding unvaccinated kids. And that's an ongoing story, going around the camps in Moree and finding unvaccinated kids. And again, it's data. So we've got a whole stream of getting the right data from the AIR out to the health workers so they can find kids who are not fully up to date. But we also need good governance. So in the little organisation I work with is Hunter New England, but in population health, so in the public health unit, the boss has adopted a joint governance group. So on the right is the traditional governance that you sort of expect. So the boss at the top, the director, and the management committee telling people what to do. And what they've done is they've replicated that with Aboriginal people who work in the organisation. And then in the middle, there's a joint governance group, and the joint governance group has equal power so that the Aboriginal people and the traditional director, the boss, work together with neither overseeing the other. So that's a governance structure. So a lot of the stuff we're able to do comes from really good governance. And on the bottom right is the Aboriginal Cultural Determinants Committee, which very conveniently shortens to ACDC, which is pretty cool. And it helps me to remember that. There's lots of good information out there. So this is not like the like with the fires. There's Aboriginal people know how to control the country. They know how to look after the place so it doesn't go up in an inferno, but we weren't listening, and now we've got an inferno all over the place because we weren't listening. There's lots of good guides working with Aboriginal people. This is the National Safety and Quality Health Standards as a user guide for Aboriginal and Torres Strait Islander health. And there's 6 action points there, and I really commend them to you. If you're working in an organisation, you're looking for guidance for how to do things, these are absolutely fantastic. And a lot of those things in our little organisation we've done before this report came out, so that's pretty terrific. We ran an immunisation conference a few months ago. On the left is, that's Liam and Zeke and Bailey, 3 local school kids in junior high school who are learning the dig as part of reclaiming their culture, and we opened the Friday night with them. And on the right is an Aboriginal dance group from a local high school, from a local primary school. They're Aboriginal and non-Aboriginal kids. And on the Saturday morning, we had 600 people there, and we opened with an Aboriginal dance because we wanted to show that Aboriginal culture was important. Even though it was a general immunisation conference talking about vaccines and diseases and all that, we just wanted to show that. And we also led, the first speaker was an Aboriginal researcher because we wanted to show the primary importance of that. So in summing up, these are the sort of important things that if you're going to establish ongoing, meaningful, respectful relationships, you've got to engage with communities and families. So it depends what you're sort of working at. Obviously, if you're a clinician, you're working in a different way to if you're a researcher or an epidemiologist or whatever you're doing. So but you've really got to know Aboriginal people, get to know Aboriginal people. Developing Aboriginal employment opportunities is really important. We're not going to change anything if we keep it all monocultural and not have Aboriginal people as colleagues. And you can see that with Katrina's wonderful presentation and the great work she's doing as the national coordinator. And we have shared responsibility and mutual accountability. This is not Aboriginal people's job to fix everything up. Yep, this is a whole of health service responsibility. We work together. But if we're going to do that, we've got to make space for Aboriginal ways of doing things. Yep, it's not just the dominant culture the whole time. And we've got to give Aboriginal people a voice, which is what I tried to show at the beginning, that we've silenced Aboriginal people. We've got to give Aboriginal people a voice, a real voice, and spend time. Spend time with people. And I love this one. I asked an Aboriginal health worker, Paula, who I work with, I said, oh, what do I tell people about how you work with Aboriginal people? And she said, well, maybe they'll start by saying hello. You know, like just listen and talk to people. So they're the official ones. These are mine. Be fair dinkum, you know, be fair dinkum. Be real with Aboriginal people. Don't go in there. If you're in there as a researcher because you've got to tick some boxes and you've got some research to do and you're going to get the publication and you're going to get the benefit, then you really got to question what you're doing. Yeah, you really got to question what you're doing because you'll probably help someone and it'll be you. Yeah, you're probably not going to leave anything for the community there. And just treat people well. Yeah, treat people well. It's really important. And give Indigenous people a go. If you give Indigenous people a go, you'll be surprised. And there's an incredible generosity with Aboriginal people. Huge things are happening nationally at the moment. The Uluru Statement from the Heart, put together in 2017. Now, this is absolutely incredible, because in the past, Aboriginal people have been at pains to tell non-Aboriginal people that everyone's different. You know, people from Alice Springs are different to people from Cairns, are different to people from Melbourne. But they've come together in this Statement from the Heart. 300 Aboriginal leaders from around the country. Small handful of people didn't put their name to this. So that's nearly universal, putting this to the Australian people. It's written in beautiful language. I implore you to print it out and have a read of it. That's it. That's one page. That's it. It's not lengthy. Beautiful language in joining together. So there's a real reaching out. And now we've got a federal Indigenous Health Minister. So there's lots of exciting stuff happening. So if you're interested in helping Aboriginal people, we also got to follow what's happening on the national stage. And there's some really exciting things happen. And this Aboriginal people coming together with one voice is new, and it's exciting, and might be time to embrace it. Lots of people to thank, too many to mention. Every Aboriginal person I've ever met. Particular thanks to the Purple House in Alice Springs, who've done some, helped me with the, they've got a really lovely translating software, which is all new, which is quite exciting. And again, my apologies to people who speak Kluricha. And when you work with Aboriginal people, treat people with respect, be good at what you do, and you'll be surprised at things coming together, and these gaps that seem intractable will start to close up, and you'll discover a wonderful generosity working with Aboriginal people that will enrich your own life. Ta.
Great, thanks, Patrick. So two wonderful presentations. I'll just invite Katrina to come back up here and